So hello everyone and welcome to this pathology resident live unknown slide session, or PRLUSS as I would like to call it with an acronym, right? For those of you who don't know me, my name is Miruna Popescu. I'm a PGY5 pathology resident, currently based in Germany. We have a 6-year training period for those wondering why I'm still a resident in my 5th year. And we're doing AP only. And this thing started out with actually my conviction that I think residents should step in the shoes of educators, because we, not with the pretension of being experts, and teaching others, but we learn so much by teaching, by sharing knowledge. We learn so much from one another. So it's an egoistic thing in a sense that you're learning yourself by finding ways to digest the information you've read in textbooks so as to convey it to another person. So this is, you're doing good for another one that's learning from you, and you're doing good to yourself because you're going to be able to retain that information more easily if you are put in the situation where you have to teach it to somebody else. So that's the whole thing. That's happening here. All we want to do is get together as trainees and share knowledge, look at cases together, and learn from one another and have a good time. And for those of you who don't know me, I am very active on Twitter, and I am mostly interested in GU, GYN, and bone and soft tissue. Still finding my way to bone and soft tissue because I don't get to see that much of it, but still it's one of my interests. So the majority has chosen in this. I think we're going to make this a recurrent thing. I hope we're going to make this a recurrent thing, maybe once a month. I don't know. We'll figure it out. We have a Twitter group, so we'll discuss everything there. If you're interested, you can DM me on Twitter. I'm open to any discussion. I'm very casual, as you can notice. And yeah, so this is the idea. Today, in this session, at least, we're going to focus on pink renal tumors. And I call this part 1 because I won't have the time to go through all of them, right? Because we have some pathology applicants among us, and I want to keep this as simple as possible, right? And be able to have time to, focus on your questions, because that's the whole idea behind this. Okay, so let's move on. I hope you can all see my screen. The images in the video, like I want to give some credits to Dr. Katrina Collins from the pathology department of the University of Indiana. She kindly provided most of the pictures in this video, and also to Path presenters. So these are great. Like her Twitter or X account is great. She shares one of the most impressive photos that I've ever seen. The quality is amazing. And Path Presenter is also a great resource to learn, right? To look at virtual slides. So let's start with our first case, case number 1. Mostly, I'm not going to give any history with these because it's mostly going to be a something-year-old man or woman presents with a renal mass, right? So we're going to skip that part and get straight to I'm going to give some gross info though. So this was a solitary mass, say 6-7 centimeters, that was well circumscribed, as you can also see in this low power image of it, and it had a mahogany brown color, right, with a central scar. I'm already giving up too much info, right? So for the junior trainees and the pathology applicants, right? What do you want to do? How do we want to approach a slide? First, we look at low power. I know there's this urge of going to high power, but low power can give us so much info, and some features we cannot appreciate on high power. So we have to start at low power. What do we see at low power in this image? Well, first of all, we see that we are in the renal cortex. We can see some glomeruli here and there, right? We see that we have a mass that appears to be well circumscribed, but unencapsulated. It has some more cellular, hypercellular areas and some more hypocellular edematous areas, right? We do see some in the edematous areas, we do see some cystically dilated tubules or structures. And there is also some, right, fresh hemorrhage as well. Great. Let's move on. Let's zoom in. Now we can go to higher power, right? And let's focus on the more cellular areas, right? So we see there's a solid, kind of a solid nested growth pattern, these discrete nests that are, you know, pressed together, and these more edematous areas with the nests floating in these edematous areas. Let's go a bit further. Okay, let's now appreciate the cytological features. So these cells are very pink, and the idea in renal tumors, always, we try to find the pattern because we have multiple patterns, and we try to fit the tumor in one of these patterns because each pattern opens up a list of differential diagnoses. And then applying immunohistochemistry and looking at other morphological features, we can narrow it down to the correct diagnosis. So the patterns in kidney neoplasia, they're multiple. Some refer to cytological features, such as when we say clear cell pattern or eosinophilic cell pattern, and some refer to architectural features. For example, when we say tubulocystic pattern, when we say papillary pattern, when we say infiltrative pattern, right? So these are mostly gross, like growth patterns, right? But for the purpose of this session, now we're going to focus on the clear cell and eosinophilic cell patterns. So in this scenario, we're in the eosinophilic cell pattern, right? And this opens up a spectrum of different entities that we have to consider. If we were in the clear cell pattern, we would, of course, think of clear cell renal cell carcinoma, the conventional chromophobe renal cell carcinoma, right? We would think of papillary renal cell carcinoma with clear cells, because we can have that sort of clear cell change in papillary renal cell carcinoma, right? So we would have a lot of a spectrum of differential diagnoses, ranging from renal cell neoplasms to renal hemangioblastoma, and it also fits into that. Epithelioid AML also fits. Angiomyolipoma also fits into that case. But we're now into that, we're now into that eosinophilic cell pattern. So the eosinophilic cell pattern, like, also has the clear cell renal cell carcinoma as one of the differential diagnoses. And you're going to say clear cell and in the eosinophilic cell pattern? Yes, because there's this feature that is pretty specific to clear cell renal cell carcinoma, and it's called nuclear cytoplasmic synchronization. Meaning, the more higher grade the nuclei get in a CCRCC, the more eosinophilic the cytoplasm is going to be. So it's this, they synchronize, right? So high grade clear cell renal cell carcinoma is going to be a differential diagnosis in the eosinophilic cell pattern. Other differential diagnoses are oncocytoma, the eosinophilic variant of chromophobe renal cell carcinoma, right? You're always also going to have more newer entities such as low-grade oncocytic tumor, eosinophilic voculated tumor. Of course, you can have papillary renal cell carcinoma. Papillary renal cell carcinoma can have oncocytic cells, and papillary renal cell carcinoma is a common tumor, right? One of the most common RCCs, so definitely in the differential. Now, we've opened up this box of things, a lot of things, right? What do we want to do next? We want to look at the architecture. So we said solid nests in an hypocellular edematous stroma floating around. So it is not a diffuse sheet-like architecture, right? And then we want to look at the cells. We said eosinophilic, finally granular cytoplasm. This is what makes it oncocytic. Oncocytic in every organ system is not limited to the kidney. You can see it in endocrine organs, in the thyroid. You can see it everywhere. Oncocytic cells have an accumulation of mitochondria in their cytoplasm. And this imparts that eosinophilic and finely granular appearance of them. If you would do electron microscopy, you would see lots of mitochondria that, like, you know, engorge the cytoplasm. So this is what we have here. We have oncocytic cells. Let's pay attention to the nuclei. The nuclei, at least in this field, this is not the most high power field, of course, but in this field, at least, you can see that they are pretty round and uniform. There isn't much atypia. There isn't much pleomorphism. Pleomorphism meaning variation in size and shape of the nuclei. They're pretty monomorphic. They look kind of the same, you know, size. So not very atypical. So now my question to you is, what do you think this is? From that whole box of, anybody wants to chime in and say their thoughts? Don't be shy. We're between friends. I see a lot of people writing oncocytoma. Yes, 100% true. This is an oncocytoma. And of course, we would like to apply some stains to prove it is an oncocytoma. Yes, I forgot to do this. That's right. Okay. So please be sure to mute, right? So that we can continue. Great. So the thing with this is, so oncocytomas would be CD117 positive. They would be typically negative for CK7, but you may see CK7 staining in rare cells. And vimentin is negative, as well as hell colloidal iron. Let's look a bit further. Let me show you another example of this, right? And discuss a bit. So oncocytoma is one of the few benign renal cell tumors that is frequently discovered incidentally on imaging performed for other reasons. So grossly, it's cortical based, as we can see here as well. We see the glomeruli, so we're in the renal cortex. It is usually well circumscribed, non-encapsulated, and mahogany brown with a central or peripheral scar. This is like the typical appearance of an oncocytoma. Now, this is another very, very nice you know, correlation between gross morphology and microscopy. The more this term mahogany brown, the more brown a tumor gets, the more eosinophilic it's gonna be under the microscope. It's not always true, but it happens. So you should remember that. Another thing, you're always gonna be told oncocytomas have central scars. Yes, they do, but it's not specific. Chromophore RCCs can have central scars. So it's not like you see a central scar, you're like, oh, this is oncocytoma. Might be, but doesn't have to. The median size is like 5 centimeters, but they can grow pretty big. So don't get distracted or disheartened if you see a, I don't know, 10, 12, 15 centimeter tumor. It's a bit concerning, but it can happen. You may see hemorrhage, but necrosis is typically absent. Necrosis is a sign of bad prognosis. So you'll mostly not see this in a tumor that is indolent, has no malignant potential. Histologically, what you see are solid nests in a hypocellular, loose, fibrous, or edematous, sometimes hyalinized, sometimes even myxoid stroma, in a so-called archipelago-like growth pattern. And this is something that I want you to remember. So of course, you can see variably cystically dilated tubules, or also a common feature, not only nests. But what I want you to remember is this archipelago-like growth. Like if you would imagine the stroma, this hypocellular, loose, fibrous, edematous stroma to be a sea, and the nests of cells floating in it are islands, like in an archipelago. This is the typical growth pattern of an oncocytoma. And like we said, we have nests, but we also have cystically dilated structures, like tubules. We can also have tubules that are not cystically dilated and are very closely packed, also growth pattern of oncocytoma. What you shouldn't see in oncocytoma is a prominent papillary pattern. If you see a prominent papillary pattern in something that in an oncocytic renal cell neoplasm that you think might be an oncocytoma, think again. It probably represents a papillary renal cell carcinoma with oncocytic cells. So apply the appropriate immunohistochemistry to prove, do AMACAR, for example, which will be positive, right, in papillary, to prove it's not oncocytoma. But remember this pattern, right? Again, the stroma, loose, fibrous, edematous, hemorrhagic in some areas, and discrete nests of cells that float, like I said, they're scattered in the stroma, like islands in a sea, right? This archipelago growth pattern, remember it. Now, regarding the nuclear features, so we have said, before we get to the nuclei, I want to give you an algorithm to approach pink renal tumors. So we say they're oncocytic, meaning they have this eosinophilic finely granular cytoplasm due to accumulation of mitochondria, right? That's what makes them oncocytic. It's true, like I said, it's true for any other oncocytic tumor and any other organ system that you can think about. So with eosinophilic kidney tumors, we focus on architecture. That's why I want you to remember that archipelago-like growth, and on 3 cytological features that are concerning cell membrane, cytoplasm, and nucleus. Let's apply this to our example. So there are no prominent cytoplasmic borders in this case. You can see the cells are kind of discohesive in the sense that you can see some small, small spaces between the cells. They do form solid nests, but in between the cells, there's like this clear space, meaning you don't see prominent cell membranes, right? You couldn't draw a line and say, this is the cell membrane. Okay. So the cytoplasm is, as we said, eosinophilic, finely granular. But another thing that we look for, we don't see any prominent perinuclear clearing of the cytoplasm. You might argue, well, there are some cells like here in the top right corner of the picture that have a delicate, not well-formed perinuclear clearing. There is some clearing here, you might argue. Some of the cells do have that, but it's not prominent, it's not robust, and it's not diffuse. Some scattered cells may try to have some perinuclear clearing, right? The nuclei themselves, the nuclear membrane, uniform, no nuclear membrane irregularities. The nuclei are round and uniform. They have finely dispersed chromatin and visible nucleoli, right? This is the typical description of an oncocytic cell, right? The vesicular nucleus, the nucleolus, right? And the round central nuclei. Some scattered cells in this example, when I first look at the picture, of course, I'm not going to find it now when I have to show you, but some are binucleated. Happens focally. It's not the prominent feature. It may happen. Okay, let's move on. Now, what I want to show you here is that oncocytomas may have some concerning histological features that shouldn't dissuade you from making a diagnosis of oncocytoma if the other features are otherwise perfect for oncocytoma. One of them is at the microscopic level, meaning you may see areas, focal areas, with this prominent pleomorphism. Cells that have big nuclei, hyperchromatic, bizarre looking, smudged chromatin. And you're like, oh my God. Well, she said that they're not atypical. What is this? What is happening? What is happening is that this is called degenerative type atypia. This is not true neoplastic atypia. And this is something, again, that you see across organ systems. Every oncocytoma in the thyroid, right? In the parotid gland can have this focal, what we call endocrine atypia in endocrine organs, this slight focal variation in size and shape of nuclei. It's normal, right? It shouldn't dissuade you. As long as this is not accompanied by increased mitotic activity. And again, let me tell you, in fact, so oncocytomas, if you manage to find a few mitoses after thorough search in an oncocytoma, think again, that's not an oncocytoma most likely. Mitoses are very rare in oncocytomas. So much so that they've put a picture in the WHO with it showing an oncocytoma with a mitosis. Something never seen before. So this case had a focal area that looked like this, but most of the tumor looked like the picture on the right-hand side of the screen. Monomorphic, round nuclei, no atypia. So this was an oncocytoma. At the same time, other gross features that are concerning is oncocytomas can go big. They can invade perinephric fat, they can invade sinus, renal sinus fat, and they can invade veins. Now tell me, you'd be a bit reluctant to call that something benign when you see something like this, but it can happen. So in an otherwise typical oncocytoma, features such as pushing invasion into the perirenal fat without any desmoplastic response shouldn't dissuade you from making the diagnosis of oncocytoma. So these are features like to keep in mind. Regarding the immunohistochemical profile, we talked about it. CD117 will be positive, membranous. I don't have a picture to show you. CK7, typically negative, but some positivity in scattered cells or small cell clusters is acceptable. Vimentin, negative. It is important. Vimentin is important because it is essentially negative in all oncocytic renal tumors. It helps in distinguishing from it helps from distinguishing this from high-grade clear cell renal cell carcinoma, because I've told you about that nuclear cytoplasmic synchronization. The more high-grade the nuclei, the more pink it gets. Well, the more vimentin it will express. You can think of it this way, like in this sort of progression. So a high-grade clear cell renal cell carcinoma will express more vimentin than a low-grade clear cell renal cell carcinoma. So vimentin helps because it will be typically positive in a high-grade CCRCC, but it will be negative in an oncocytoma. Another thing, it helps distinguish from papillary renal cell carcinoma with eosinophilic cells. Those are also positive for vimentin, so it helps. One thing to remember, if the oncocytoma has a central scar, in the central scar area, you may see increased expression of CK7 and vimentin, but like a bunch of it. And you're gonna say, ooh, what is this? In a biopsy, that's awful, because if you just sample the central scar area and you see a lot of CK7 and a lot of vimentin, you're like, ooh, what am I gonna do? You know? But in a resection specimen, be aware of the geography, where you are in the tumor, right? Good. So this is a pitfall. Hale colloidal iron, I told you about this. We don't typically use it because it's hard to optimize. One good internal control is that if it's well optimized, it should highlight the glomerular cells with minimal or no staining in the proximal tubule. This is like an internal positive control for it. But classically in textbooks, it should be negative in oncocytoma as opposed to chromophobe, right? One thing to remember is that if you have this sort of just apical, right, luminal staining with this blue, like it stains blue, this stain, it's considered negative. You would have to have full cytoplasmic, diffuse cytoplasmic expression for it to be considered positive and lead you towards chromophobe renal cell carcinoma, because this is actually the main differential diagnosis, right? Oncocytoma, chromophobe renal cell carcinoma. One is benign, the other may metastasize, right? May show sarcoma-type transformation, whatnot, right? And be aggressive. So it's a carcinoma, the other one. Great. Another morphological pattern of oncocytomas is when you have a preponderance of smaller cells that have densely eosinophilic cytoplasm, and these are called oncoblasts. You may see them scattered in an otherwise typical oncocytoma, but sometimes they predominate, and they have a particular morphology. When they predominate, they tend to form this pseudo-rosettes or microacini, you know? So the cells are polarized around hyalinized basement membrane material. And this, for the people that know a bit more about geopathology, you would say, this kind of resembles TFEB altered renal cell carcinoma. Because in that, we're also taught about this like bigger cells at the periphery, like building like a cystic structure, and inside you'll have, you know, these pseudo rosettes. But this is actually just an oncocytoma. Sometimes, if you look around the tumor, right, if you sample correctly and look like around the tumor, you'll find areas that are more typical for oncocytoma. But I just wanted you to, you know, see this pattern and think about it, right? Think about oncocytoma when you see this, not just rare stuff such as TFEB altered RCC. Another thing is, well, we're talking about TFEB, right? So another thing is that sometimes oncocytomas may show strong nuclear expression of TFEB. But this is, you know, always with immunohistochemical stains. This is for the juniors. You always have to think, what is considered positive, right? What is specific? What compartment of the cell has to stain for me to call that, you know, positive? So with TFEB, if you want to talk about TFEB alterations, you will have to have nuclear and cytoplasmic staining, like in the picture on the right, not just nuclear staining. This was a case of a hybrid oncocytic tumor, like a tumor that had hybrid features between oncocytoma and chromophobe, like you sometimes see in Birt-Hogg-Dubé syndrome, right? That showed this pattern of staining. So be aware of this IHC pitfall, right? Now, a bonus case. Was anybody here that noticed this little thing next to the mass? What is it? What do you think at this far it could be? Any ideas? You can write them in the chat if you want. Okay, somebody says papillary adenoma. Papillary adenoma, for that, it's a bit too eosinophilic. My impression of it. It's a bit too eosinophilic. Papillary adenomas are more like your, you know, former type 1 papillary renal cell carcinomas that are more basophilic. But I'm going to show you what this is. This is in the spectrum of papillary neoplasms, so it's good. Somebody says it's a small PRCC. Yeah, well, pretty small for that. What this actually is a so-called papillary renal neoplasm with reverse nuclear polarity. God, I don't even want to say the acronym. PRN something, right? What this is listed under, in the chapter in the WHO, it's in the chapter of papillary renal cell carcinoma. This was considered previously to be, this was called oncocytic papillary renal cell carcinoma because it has papillary architecture, it has oncocytic cells, and it was considered as that. But the thing is, it turns out it doesn't have, it's indolent. It doesn't have any metastatic potential, at least not until now, or at least to my knowledge, there haven't been any reports of metastases. So why call it RCC? So the name was changed to better reflect its indolent clinical behavior and morphology as well. This is composed of thinly branching papillae that are lined by oncocytic cells with reverse nuclear polarity, in the sense that the nuclei, instead of being at the base of the cells, they are arranged at the apical portion of the cell, right? They have a peculiar sort of, right, immunohistochemical profile in the sense that, like papillary RCC, they're positive for CK7. They show less amicroid expression as opposed to conventional papillary renal cell carcinoma. They are Vimentin negative, which on the other hand would be often positive in papillary renal cell carcinoma. And one thing that they show is a consistent, diffuse, strong expression of GATA3. So this is a helpful marker in this sort of neoplasm. Another thing, molecularly, they're different from, papillary renal cell carcinoma. They show recurrent KRAS mutations. So this is what it is. And just one extra higher power picture to show you how the nuclei, like if you think this is the fibrovascular core, right? This is the fibrovascular core. These are our cells. The nuclei, instead of being arranged here alongside the fibrovascular core, they are at the surface, right? Exactly. So this is what it's called reverse nuclear polarity. Okay, case number 2. We have this tumor. It's mostly solid, right? It's mostly solid. It's pink, and I don't see that much stroma, so not much that we can say at low power, actually. It's a bit of a fragmented specimen, so we cannot appreciate any, adjacent structures and their relationship with the adjacent structures. Going a bit high power, we see that diffuse growth. We have some incomplete fibrovascular septa, right? But mostly it's a bit diffuse, right? Solid. The cells are pink, and even from this power, we can appreciate something that is going to be very helpful in this tumor. But let's do our exercise, right? Cell membranes, are they prominent? Well, kind of. I mean, as opposed to our oncocytoma before, you can kind of draw lines with these cell membranes, right? You don't see that those clear, like small spaces between the cells, right? The cytoplasm. Yes, eosinophilic, granular, oncocytic, we get it. But what do we see? We see very, very prominent perinuclear, robust perinuclear clearing, right? There's this perinuclear halo that we see with these cells. Some are binucleated, and well, actually a lot are binucleated if you look at it, right? So can you please mute your microphones? I don't know, somebody's talking. Okay, good. Just so you know, so we can hear each other. Good. So robust perinuclear clearing. Great. We get to the nuclei. How do these nuclei look? Do they look all the same size and shape? Not really. I mean, some are round, yes, but some are very irregular and kind of remind me, at least they remind me of coilocytes with this perinuclear, halo and this kind of, wrinkled nuclear membrane. They are hyperchromatic. The chromatin is they're very hyperchromatic, and irregular. So they kind of resemble coilocytes. So what would be your differential in this? What would you think about, or your diagnosis? Maybe you can, make the diagnosis. Perfect. People are saying chromophore RCC. This is what it is. This is chromophore renal cell carcinoma, the eosinophilic variant, because this is the one that's going to cause us trouble with distinguishing it from oncocytoma and whatnot, right? In this example, CD117 diffusely positive, right? Good. CK7 was positive, but I don't have a picture to show you, and I regret for not having one to show you, but it was, you would see more positivity with this as compared to the oncocytoma. And so instead of having just single cells, you'll have like bigger groups of cells that are positive. Vimentin, again, negative, good. Because with this sort of nuclear atypia, we kind of want to do Vimentin and or CA9 to try to distinguish it from a high-grade clear cell RCC. And Hale colloidal iron was positive, diffusely positive cytoplasmatic, not just that apical bar, but diffuse entire cytoplasm, right? So the diagnosis is chromophore renal cell carcinoma. Now, classic chromophore renal cell carcinoma would fall into the clear cell pattern, of renal cell tumors. Is the third most common renal cell carcinoma after CCRCC and papillary. So you have to think about it. Grossly, again, cortical-based tumor. It's often large. It's larger than oncocytoma. Median size is like 8 to 10 centimeters. It's mostly well circumscribed and unencapsulated, but you might see a partial capsule. Most frequently, it is solid, rarely cystic. And the more eosinophilic the tumor gets, I already hinted to this, the more brown its cut surface is going to get. So it's important because you can already kind of tell, right, at crossing. It may have a central scar, like I said, in about 15% of cases. And because it's an RCC, you may see necrosis, you may see aggressive features, invasion into, soft tissue and veins. So this would be, your classic chromophore renal cell carcinoma. You see a solid or trabecular growth pattern. The latter is imparted by the fact that you have incomplete, often hyalinized, such as in this example, fibroblascular septa that kind of separate the tumor into bigger chunks of trabeculae. But it can also be solid. It has an admixture of large cells with voluminous, clear to finely reticulated or foamy cytoplasm, and smaller cells with densely eosinophilic and granular cytoplasm. And you have an admixture of these. And depending on which of these cells predominates, you can have the eosinophilic variant of chromophore RCC. There's a distinction in the bigger cells, the larger, you see the admixture here, right? You see the cells that have clear cytoplasm, and some cells are more small and they have are smaller and they have eosinophilic cytoplasm. But let me Let me show you a bit of a close-up, right? So admixture of cells, right? Now, on if you were to look on electron microscopy in the cells that have this, notice this cytoplasm, right? It's clear, but it's not optically clear, like you don't see anything like here. It's mostly, or at least sometimes, it's reticulated, finely reticulated, foamy. This is imparted if you would look at electron microscopy, as I was telling you with oncocytic cells. You will see that these cells have a lot of microvesicles, small vesicles inside the cytoplasm that imparted this reticular architecture. But yeah, enough about this, right? So another, like going through our algorithm, right? We're looking at the cell membranes. We typically have prominent cell membranes in chromophobe renal cell carcinoma. They have been likened to those of plant cells, so plant cell-like cell membranes. The cytoplasm shows prominent, robust, diffuse perinuclear clearing, those perinuclear halos. And the nuclear morphology, I want you to remember this, the nuclear morphology is the most important histological feature to pay attention to when you're trying to distinguishing between oncocytoma and chromophobe or other oncocytic tumors in between. Because in conventional, even in the eosinophilic, like we've seen, chromophobe RCC, the nuclei have prominent nuclear membrane irregularities, so-called wrinkled or racinoid nuclei. The chromatin is coarse. The nuclei are hyperchromatic. There's more atypia and variability in size and shape. And binucleation or multinucleation is common in these tumors, right? This is an example that has a lot of more of those large pale cells. And another soft clue that I want you to remember about chromophobe, conventional chromophobe, is the fact that the large pale cells have such voluminous cytoplasm that they appear to be lacking nuclei. Look at this. You might be tempted to say these are vacuoles inside the cytoplasm, but actually this is the whole cytoplasm of a cell. This is a cell. Where's the nucleus? Well, there is so much cytoplasm that the plane of section completely misses the nucleus. So it's not there. In some cells you see it, and some you don't. This is a soft clue, especially when you're trying to distinguish between chromophobe, conventional one, and CCRCC, right? Notice there's focal renal tubule entrapment at the periphery of the tumor. This can also be seen with oncocytoma and sometimes can give rise to papillary tumors that occur within, like there's a separate tumor within the oncocytoma or the chromophobe. Okay, this is an example that has a lot of clear cells. So this would definitely go into the differential diagnosis of a low-grade clear cell renal cell carcinoma. But this is, beyond the spectrum of this talk. Now, what do you do when you have this? These are both chromophobe renal cell carcinomas proven by immunohistochemistry, right? What do you do when you have this? Well, sometimes you just have areas that look like this and areas that look very, conventional. But sometimes you only have this, so what do you do? What I want you to remember is that chromophobe, Hafsa, stain it, of course, stain it, clearly. But let me tell you the gist here with staining, right? So first of all, chromophobe can have a diverse range of growth patterns. Like I've just shown you these examples, but there are, if you look it up in the internet and in publications, you'll see they can be tubular, they can be adenomatous, they can be papillary, they can be whatever they want to be. So they can have all sorts of morphologies and frequently within the same tumor. So there's a high rate of intratumoral heterogeneity, meaning that is why you'll see in the WHO, if you read the chapter on oncocytoma, you'll see that the WHO says you cannot make a reliable diagnosis of oncocytoma on biopsy, on corneal biopsy, because of that intratumoral heterogeneity, right? So most experts top line their diagnosis as oncocytic renal neoplasm, and then see comment, and they add an explanatory comment mentioning this intratumoral heterogeneity of chromophobe renal cell carcinoma and why they cannot make a definitive diagnosis of oncocytoma. Because if you look here, we have eosinophilic cells. Yeah, there are some prominent, cytoplasmic membranes, but the nuclei, they don't really. Some nuclei do. You're gonna argue, well, this one looks a bit bad, but what if it's that, difference in or degenerative type atypia that we see in an oncocytoma, right? This one has a bit more prominent perinuclear halos than you would expect in an oncocytoma, so it kind of, leads you into the direction of the right diagnosis. The thing is with staining. The thing is with staining is that in an eosinophilic chromophobe renal cell carcinoma, because that's where most of the problems arise, right? You would be tempted to say, well, I'm going to do a CK7 and I'm going to see negative or only isolated cells in oncocytoma, and I'm going to see diffuse staining in chromophobe. Problem solved. The more eosinophilic the chromophobe renal cell carcinomas get, the less cytokeratin 7 they're going to express. What are you going to do about that? So bad, right? It's not helpful. You're going to see, now the WHO says that, well, most do retain some CK7, of course, and it's expressed in contiguous groups of cells. That is more than it's accepted in oncocytoma. But what do you do if you have limited material on a biopsy? These are controversial things that I would, defer to the experts. But just to give you a nuanced, a view of this whole issue, it's not that clear cut as we're making it here, right? At the same time, like I said, hale colloidal iron, you can forget it. In some labs, it doesn't work, so it cannot be optimized. So you're mostly relying on CK7. That's why I'm telling you, morphology trumps IHC sometimes. Paying attention to nuclear features, that nuclear membrane irregularity, hyperchromasia, those wrinkled nuclei, and the perinuclear clearing, if it's robust and well-formed, will help you in most situations in this differential. Now, another quick thing to say is that, well, you can have tumors that have areas that look very oncocytoma-like and areas that look chromophobe. Like if you had it's like biphasic tumor. These tumors are called hybrid oncocytic tumors, and they are mostly seen in Birt-Hogg-Dubé syndrome. So if you see something like this, especially if you have multiple tumors or what it's called renal oncocytosis, you might want to consider looking in the patient chart, see if they have any history or suggest that they may have this syndrome. Another thing is some tumors are borderline. Like you don't have areas that look like this and areas that look like that. You have a mixture of, you cannot call it, it's too much atypia to call it oncocytoma, but it's not enough to call it chromophobe. What do you do with those? A lot of different terminologies have been used to describe these. Some describe them as oncocytic tumors with borderline features. But the GUPS, I think, recently proposed a term called oncocytic renal neoplasm of low malignant potential to use in these, scenarios. But enough about this. What I want you to remember, I put side to side an oncocytoma, the nuclear features. Remember the nuclear features and the perinuclear halos, right? Remember, these are very important. And I've put together these pictures so as to show you the round and monotonous, right, uniform nuclei that you see in an oncocytoma with a bit of size variation here and there as it happens in oncocytomas, right? And no robust perinuclear clearing, a bit here, you might argue, but again, not robust. And at the other side of the spectrum, the chromophobe with that prominent perinuclear clearing and the wrinkled hyperchromatic coilocyte-like, nuclei. And also, the staining profiles. Remember CK7 reduced expression in eosinophilic variant of chromophobe. And remember, if you're using hale colloidal iron, that apical bar or luminal only staining is considered negative. And also remember the pitfall with the central scar, that you may have increased expression of CK7 environmental. Yeah, I love it. Chromophobe is the L-cell version in the kidney. Yes, amazing. I totally agree. Do you see prominent nucleoli in chromophobe? Well, you may see prominent nuclei. Mostly you have this coarse chromatin and wrinkled nuclei, but you may see. This is I mean, you can see it.
Hi, Dr. Meduna. Can I ask one question? I'm
Yes,
sorry.
please.
Okay, so so you when you mentioned the chromophobe like variant and like you are getting in a one section in the uniform chromosome with all the features, and then you are going to get a some section a hybrid where it's more like oncocytic type, right? And there you're not getting the nucleus like prominent like resin type of nuclei or perinuclear
Mm-hmm.
halo, and then you have confusion, right? So how you are going to write that like final diagnosis, like how you're going to mention it, like it's more like a chromophobe with the area of oncocytic type or something like that.
So I think it depends in the sense that if you have areas that are conventional chromophobe, like they look like in this picture right on the right, like they're conventional chromophobe renal cell carcinomas, and you have areas that are more eosinophilic but look kind of oncocytoma like. You have to pay attention, how much nuclear atypia you have in the sense of nuclear membrane irregularities, that how well formed is that perinuclear clearing. If you don't see that and that area looks strikingly oncocytoma like, you might consider, I mentioned that hybrid oncocytic tumor, where you have areas that are purely like they look like chromophobe, and then areas that look exactly like oncocytoma. You may consider that. Look into the patient chart, see if they have any history of. So Birt-Hogg-Dubé is an autosomal dominant disease. It's characterized by multiple fibrofolliculomas, multiple pulmonary cysts with repeated pneumothoraxes, spontaneous pneumothoraxes, and oncocytic renal tumors in this spectrum. Usually these hybrid tumors between oncocytoma and chromophobe. So look into the patient chart. Maybe they have this, maybe they have signs of this, Look into the adjacent kidney, non-involved. Maybe you see oncocytic change in non-neoplastic renal tubules is also a sign. Or you see small oncocytomas here and there, These are signs that this patient is a syndromic patient, And this might represent that hybrid oncocytic tumor. Otherwise, in other tumors that have this like a mixed morphology, you have like areas that kind of look in between chromophobe and oncocytoma, areas that kind of look very much like chromophobe. Here is debatable whether you want to call it oncocytic, that oncocytic renal neoplasm with low malignant potential, or whether you want to outright call it chromophobe. If you have areas that are very clearly indicative of chromophobe, you also have to look at size of the tumor. Does it show invasion? Because if you would have a tumor that has chromophobe features, at least focally, you see areas that are convincingly chromophobe, and it invades in vessel, it invades into perirenal fat. You're gonna want to call this chromophobe, I assume.
But oncocytic also can have the perinephric fat invasion,
Yes,
right? Like
yes,
pretty possible.
but I'm talking about scenarios where you definitely have areas that look like chromophobe renal cell carcinoma.
Oh, great.
The idea with invasion, you're disregarding invasion into fat and stuff like that. If you have something that looks 100% like oncocytoma, it looks 100% like oncocytoma. If it doesn't look 100% like oncocytoma, maybe you would like to call it oncocytic renal neoplasm of low malignant potential. Maybe you would want to do that to give the clinicians the benefit of the doubt, to give that patient the chance of being, surveilled and so not sent home and you're done. It was an oncocytoma. Bye-bye, because if it's not 100% oncocytoma and it shows these aggressive features, maybe you don't want to call it outright chromophobe, but you would want to put that category of low malignant potential, at least to signal that this may be malignant, And there are some studies, actually there is some data that has said that surveillance can actually be a viable option for eosinophilic chromophobe renal cell carcinoma. So they may actually not be, they are, chromophobe in general is not that aggressive as clear cell. And the eosinophilic variant seems to be even less aggressive. I hope I've answered your question with this.
Oh yeah,
Um,
thank you so much. Thank you so much.
no worries. Somebody is actually asking about LOT and SDH. We're gonna come to that. Wait a second. Okay, so let's move on. Let's move on to case number 3. We have this tumor, which is, we again don't have any, renal parenchyma that is visible here in this just a section of the tumor. It's very solid. First thing that we know is at low power, it's pink, it's solid. I don't see nested trabecular, nested or trabecular growth or stuff like that. Okay, so it's solid. Let's go to a bit of a higher power. We've seen this area on low power, right? A bit more hypocellular, a bit more edematous, loose fibrous, whatever. Not that many cells. And we kind of see, maybe you could imagine this is sort of a sharp transition between these more solid pink areas and these areas that have this hypocellular stroma and strands, interconnecting strands of cells that float into it, right? Maybe this kind of rings a bell of what this could be. And now going to higher power, let's do our exercise again, right? Nuclear membrane, no, sorry, I'm dumb. Cytoplasmic membranes, prominent or not prominent? Well, there are some. I mean, arguably you could say some of these cells have visible cytoplasmic membranes, but it's not screaming at it. It's not plant cell-like, right? Cytoplasm, eosinophilic, granular, we know the drill, right? Oncocytic. Perinuclear clearing, definitely. There's definitely some perinuclear clearing. It's not everywhere. It's not everywhere. Some do have. Some are very, delicate, not that well formed, but it's there. It's there. It's happening more than you would expect in oncocytoma. So this kind of pushes you a bit towards chromophobe, but then you get to the nuclear features. These are round, monotonous nuclei. I don't see any nuclear membrane irregularities. Maybe you do. Maybe I don't. I don't know. For me, they're pretty monotonous. Some cells are binucleated. A lot of them are actually. But, this kind of pulls me back towards oncocytoma. So where am I left? What am I going to do? Does this resemble oncocytoma, or does this more resemble chromophobe? Eosinophilic chromophobe in this instance. So anybody has any ideas about what this could be? Write it in the chat. Shout it in the chat. Or shout it directly here to scare everybody. No? Nobody? Jackson, this is for you, because you asked. Well, that's a consideration. That's a consideration. Let's say TFE3 was negative. Okay, SDH. That is also a consideration, but is SDH retained? It's good. Those are very good differentials, right? We do the SDHB stain is retained. This is CD117 negative and CK7 diffusely positive. Exactly. This is LOT. Yes, low-grade oncocytic tumor that we like to call LOT because we have a lot to learn about kidney neoplasia. I'm doing dad jokes. I'm bad. Okay, let's move on. Great. So this was the staining pattern in this case, right? CD117 negative, CK7 diffusely positive. Pale colloidal iron negative, showed that apical bar, but we said that's negative. Vimentin negative, good. We're not in a, CCRCC spectrum or papillary or whatever, right? CA9 was positive, but focally, very focally. So this is a pitfall, but it happens. CD10 also focally positive. Amacur negative, yeah, for papillary, and SDHB retained. But what I want you to focus on, so low-grade oncocytic tumor, right, is this pattern. So CD117 negative, CK7 screamingly positive in a tumor that has this sort of, in-between morphology should lead you towards thinking, oh, this may be LOT. This should ring a bell. This could be LOT. What I mean by in-between morphology, the cell membranes kind of, resemble chromophobe. The perinuclear clearing, although not that prominent and well formed, it's pretty subtle, but it's there. kind of push towards chromophobe, and then we get to the nuclei and everything goes, it goes back. We're like, what is this? Right? So low-grade oncocytic tumor is a provisional entity. It's listed under other oncocytic tumors in the current 5th edition of the WHO. The name tumor reflects its indolent biologic behavior. As far as I know, there haven't been any metastases reported in this, right? So that's why it's called tumor and not carcinoma. In the past, this was most likely misdiagnosed as either oncocytoma or eosinophilic chromophobe. But again, notice the visible discrete cell membranes, right? The oncocytic cytoplasm with diffuse but delicate perinuclear clearing, not that robust. And, this sound until now, this sounds as chromophobe. But then again, the nuclei kind of push you back to thinking, oh, this kind of looks, the nuclear features are kind of resemble oncocytoma. Here's another example, maybe a better example, like a textbook example of what I wanted to show you in terms of architecture. We've discussed cytology with LOT, okay? Architecturally, it can also point you towards LOT. The fact that it's solid, sheet-like, oncocytomas have this, nests that are in this hypocellular stroma, archipelago-like growth, remember? LOT typically is solid and abruptly transitions, like here, to a hypocellular edematous stroma. And you have then the tumor cells kind of form these, cords, anastomosing cords, or small clusters, or even single cells that float into that stroma. This has been likened to boats in a bay. This is beautiful. I mean, this example is beautiful. You have the continental ground, then this is the shore, and this is the water, and these are the boats, the yachts of rich people that, float in the stroma, in the, what I mean. So I think this is amazing. This is a great example for that. If you see this, think about LOT, along with the other features. Because, you could also say, maybe this is the central scar, I don't know, but oncocytoma. So, but think about this. Again, this is a close-up to show you that sometimes it's been called tissue culture-like, and you can see where that comes from, right? Because although these cells are pretty plump, right, for those mesenchymal cells that we usually think about when we say tissue culture-like, but in a sense, it's there. You can imagine. In this example, we saw we see osseous metaplasia. Osseous metaplasia is not specific. It can also be seen in oncocytoma. So, but I just wanted to show you this picture as well, because it's interesting to see that it can happen. And also appreciate the solid growth, right? This is not a typical growth of an oncocytoma. They don't have those discrete nests, right, that are floating in the stroma. The pattern that I want you to remember, CD117, dead negative, CK7, screamingly positive. Vimentin negative, this is the positive control in the vessels. So don't worry about that, right? This is just the internal positive control. And one other thing that I want you to remember about LOT is the fact that they are consistently positive for GATA3. So if you have a tumor like this, and you're doing CD117 negative, you're doing CK7, diffusely positive, you're doing GATA3, diffusely positive. And of course, ruling out other things like doing SDHB to rule out SDH deficient. There is this low-grade FH deficient RCC that's been circulating. So you can do FH to prove that it's retained and everything like that, right? But if you see this combined with the morphological features, the solid growth, that boats in a bay pattern, and cytology that is between chromophobe and oncocytoma, you're good to go with a LOT. Case number 4. Any questions about this? I haven't asked about questions. I'm a bad host. No, I assume. Let's move on. Case number 4. Another tumor, renal tumor. Surprise. Well circumscribed, right? This is a renal parenchyma. Well circumscribed. It's mostly solid. This is mostly artifactual, artifactual like falling apart of the tumor, so it's not cystic. Okay, growth pattern. Pretty solid. Nests and trabeculae of cells, but pretty solid, nondescript. Stroma, again, myxoid, like whatever, edematous, loose fibrous, nondescript again. Cells, pink. Okay, we're in that pink category of tumor cells. But there's another thing that I want you to notice about this tumor. Exactly. Vacuolated looking. Vacuoles. So let's apply our algorithmic approach, right? Again, let's start with cell membranes. Are they prominent? Well, in this example, no. I wouldn't say they're prominent, right? Not really. Cytoplasm, oncocytic, right? Eosinophilic, granular. Perinuclear halos, not that much. But what else do we see in the cytoplasm? Yes, we see the vacuoles. We see prominent vacuoles, multiple vacuoles per cell. So one cell has multiple vacuoles. Some of them are very big, like big, right? Intracytoplasmic, clear, or finely reticulated vacuoles. You'll say, well, it could resemble chromophobe, right? With those smaller eosinophilic cells and the bigger cells, right? But in this, you kind of have like, you have multiple vacuoles per cell, discrete vacuoles per cell. Some of the vacuoles are very big and they do have nuclei. So it's not because the cytoplasm is very voluminous and the nucleus is not in a plane of section. So it's a bit different than chromophobe, right? It's a bit odd for chromophobe. Nuclei. Nuclear membrane irregularities, wrinkled nuclei, racinoid nuclei, coilocyte-like nuclei? Not really. High-grade nuclei? Oh, definitely. We can see prominent eosinophilic nucleoli. So, yeah, well, some binucleation here and there. So these are high-grade nuclei, but they're not that racinoid, wrinkled as in chromophobe. So we're again left sort of guessing. What could this be? Right? This tumor also happened to have, at the periphery of the tumor, thick-walled vessels, like you can see here, very thick-walled, and also vascular invasion. Whoops. So we're kind of figuring out, like, those high-grade nuclei and vascular invasion, am I willing to call this benign? But if I don't call it benign, what do I call it? Because it doesn't look like typical chromophobe. Another area of vascular invasion, you can see the tumor cells invading into the vessel wall, right? So anybody has any ideas what this could represent? Good differential, epithelioid angiomyolipoma. This is a very good differential. It's in the differential for these tumors. This is not epithelioid angiomyolipoma. And congratulations, Jackson. This is EVT. This is eosinophilic vacuolated tumor. Notice tumor, not carcinoma, although vascular invasion. What's happening? Are we going insane? This is the staining profile of this tumor. It was diffusely positive for cytokeratins. So, and it was positive for PAX8, so not epithelioid AML, right? It was positive for CD117. CK7 was mostly negative, but had some scattered cells, just like oncocytoma. CK20 was for all practical purposes negative, right? Cathepsin K was positive, patchy, but it was there. So this might fool you because we know about AML, cathepsin K, very good marker, but we have the positivity for cytokeratins and PAX8. So it kind of rules that out. We have negativity for HMB45 and melanate, which are also markers that are expressed in AML, right? It was Vimentin negative. So we've ruled out, clear cell, high-grade clear cell renal cell carcinoma and other things because we have to rule them out here in this scenario. It was CD10 positive. It's not saying that much, but it's there. And I'm going to show you how it can be helpful in this scenario, right? When you corroborate with all the morphology and everything. Hale colloidal iron was negative, and SDH and FH were retained. So we've ruled those out, right? Great. So this is, like we said, eosinophilic vacuolated tumor. This is an emerging entity with a distinctive morphology, a consistent immunohistochemical panel, and distinctive molecular features. It emerged from this category of unclassified eosinophilic renal neoplasms and was initially called high-grade oncocytic tumor, and everybody loved it because its acronym is HOT, you know. So everybody loved this. But the term high-grade kind of confused pathologists and clinicians alike, because to date there haven't been any metastatic cases, and this is an indolent tumor, and calling it high-grade, while it reflects its high-grade nuclear features, it does not reflect its behavior. So we changed it to eosinophilic vacuolated tumor. It also used to be called sporadic RCC with eosinophilic and vacuolated cytoplasm. Again, RCC, not a good term to highlight its clinical behavior. Jackson, I'm gonna get to that question soon. It's about cathepsin K, about being strongly positive. Where cathepsin K is positive in almost all cases, but it can be focal. It doesn't have to be strong positive. You can see focal staining, patchy staining, whatever, but it's typically positive in all cases. That's what you have to remember. So EVT is mostly sporadic, but some are encountered in patients with tuberous sclerosis complex. And one thing that I want you to remember about this, I haven't given any clinical info, right, for these cases, but for this one, you have to remember one thing. It's more common in women. This is a difference to most other renal cell tumors that are mostly seen in men. Well, this is more common in women, and there is a wide age range, including young people. Women in their 20s can have this. It's usually small, solitary, well circumscribed. It's a PT1A, usually very small tumors. It's rarely cystic. It's mostly solid. Very rarely you see it cystic, so mostly solid. Has a mahogany brown cut surface. It's eosinophilic, right? And it doesn't have any necrosis, usually. Okay, so it may have different growth patterns. It shows a solid growth pattern, as you can see here, but the characteristic feature is the cytoplasmic vacuoles. So that's what I want to talk about a bit. So with oncocytoma and LOT and chromophobe, we were looking at the cytoplasm and appreciating perinuclear clearing. We said, like, are they wimpy and focal versus are they robust, prominent, diffuse, and chromophobe, right? Now, we want to appreciate a second cytoplasmic feature, which is vacuoles. We did this with chromophobe in the sense that we said chromophobe, conventional chromophobe renal cell carcinoma, the cells that have big, large, voluminous, pale cytoplasm have these numerous microvesicles inside them that make the cytoplasm seem foamy, reticulated. Those are also vesicles, but they're very small. In EVT, the vesicles are large, like this, multiple vesicles per cell that are large. Some have like an internal trabeculation, but some are clear, and they don't have any material inside them. These are details, that help us to reduce the number of immunohistochemistry that we apply for renal tumors. We look at the cytoplasm, we look at the vesicles. Are they small? Are they large? How many are they per cell? Because in SDH deficient RCC, we usually see one vacuole per cell that sometimes contains this pale eosinophilic or flocculent material, which we don't see here. These are mostly clear. We don't have that pale eosinophilic material inside them, and the vacuoles are multiple per cell, and they're big as opposed to the vacuoles in chromophobe, right? So these are like nuances that we can look at, and consider. One other differential for this is the so-called eosinophilic solid and cystic renal cell carcinoma, or ESC, like the escape button on the keyboard, RCC. That's an RCC that can show metastatic, behavior. So as opposed to this, although the data that we have is pretty new, because these are new entities. So we don't have that much follow-up on these, but like general things that we know so far. And ESC-RCC, as the name implies, is usually solid and cystic, but sometimes it can be mostly solid, so it can mimic this. And EVT, on the other hand, is mostly solid and not cystic, but exceptions exist. And in ESC-RCC, you see coarse basophilic granularity that has been likened to Leishmania infection in the cells, a so-called cytoplasmic stippling, basophilic cytoplasmic stippling, that is typical of sCRCC, and we don't see it here. This just based purely on morphology and on the differentials, right? So this is something I'm not gonna go through it. It's just for you. You know, remember the fact that it's Pax8 positive, cytokeratin positive, which would rule out epithelioid AML. It's cathepsin K positive. This is like a pitfall, you know. This is cathepsin K positive. It helps with the differential with other renal cell carcinomas and renal cell tumors, but not always diffuse and strong. Can be focal, but it's there. Remember this profile. CD117 is positive. CK7, it's generally, you may have some, you know, some scattered cells that are positive. CK20 is negative. In any case, you'll have more CK7 expression than CK20, and this helps you differentiate it from eosinophilic solid and cystic renal cell carcinoma, sCRCC, which usually has more CK20 than CK7. Either CK7 is dead negative, or it's some there, but CK20 will always be more than that. And Vimentin always also distinguishes between them, because sCRCC is positive for Vimentin, whereas EVT is going to be negative for Vimentin. And what helps you to differentiate it from oncocytoma, chromophobe, cathepsin K helps, and also CD10. CD10 helps. If you add CD10, because otherwise you're going to have CD117 positive, you're going to have some scattered CK7. So it's not that specific as in LOT. In LOT, when you have CD117 dead negative, CK7 screamingly positive, that's peculiar. But in this, not that peculiar. But you add CD10, you add cathepsin K, and it helps. It helps with the differential. Last case, I'm going to go very, very, very fast for this. So this is, I'm going to give you some info here. It's an 18 centimeter mahogany brown upper renal pole mass, let's say. We have nests, kind of a solid architecture. We have some fibrous stroma, and these nests seem to like float in it. Nothing spectacular. We go a bit closer. We see the cells. We do our exercise, right? We look at the cell membranes. Are they prominent? No, not really. Eosinophilic granular cytoplasm, so oncocytic, definitely. We look at the nuclear membranes. Not that, there is some irregularity. These nuclei definitely do not look uniform and round, right? There is some nuclei that are some pleomorphism, right? And even more so in this picture. Look at these high-grade nuclei. Maybe you'll ask me, is this, I don't know, could this be that degenerative type atypia in oncocytoma? But let me tell you, this was the whole tumor. The whole tumor looked like this. It's not focal, it's pretty diffuse. So I'm kind of swaying away from oncocytoma in this scenario. So notice how some of the nuclei are pushed to the side of the cell, kind of like, if you will, rhabdoid-like morphology. They're not central like in most oncocytic tumors that we've seen so far. I think some are, but some are definitely pushed to the side, and there's some binucleation also. Some are very, spindled, pushed to the side, and they look compressed. Yeah, so anybody has any ideas about what this could be? SDH, good consideration. Retained, although it may be lost. This is difficult. AML. This is negative for keratins. It's negative for Pax8. It is, let me think. It's positive for melan A. But it's negative for HMB45. It's negative for SMA. So it's negative for cathepsin K. So is it AML? Who knows? TFE3, negative. Negative TFE3. What else could it be? Should I give you a hint? Let me give you a hint. let me give you the immunohistochemical stain that you need to think about this. Yes, oncocytic adrenocortical carcinoma. And what I wanted to tell you with this is that we have been discussing primary renal tumors, you know, without end. But the thing is, you always have to consider metastases to the kidney. Why not? They can happen. So in oncocytic tumors of the kidney, remember what I said, 18 centimeter, 20, I don't know, big tumor, upper pole, renal mass. It could have outgrown the adrenal and invaded into the kidney. Why not? It's a T4 adrenocortical carcinoma, right? So the thing is, with oncocytic tumors in the kidney, think about either it's an oncocytic or a high-grade clear cell, an RCC or a renal cell tumor, a primary, what we've been discussing so far, or maybe it's an oncocytic adrenocortical carcinoma, or maybe also include epithelioid AML. We've discussed that, right? It had been popped up in differential so far, and hepatocellular carcinoma. So my idea about this, my approach to this, you have to have these 4 differentials in your mind when you're dealing with this. You have to the idea is just to think that it exists, because if you think about it, you exclude it, you do the immunohistochemical stains, or you check the history or whatever, imagine you have a big tumor on the right side that's involving kidney, adrenal, and liver, things like this. So you have to always have it in mind. And this is like, the immunohistochemical panel that you see. I want you to remember PAX8 negative and SF1 positive. SF1 is one of the most reliable markers that we use for proving adrenal cortical origin. It has 100% sensitivity and specificity. Remember, it's not specific to the adrenal cortex. It's expressed in all cells that produce, steroid hormones. You can also see it in sex-cord stromal tumors in the, gonads. But for all practical purposes, it's the best marker you can use to prove adrenal cortical origin. Now, in the past, we have also used other markers such as, inhibin A, melon A, mesothelial markers such as calretinin, D240 have been used in a combination in a panel to prove adrenal cortical origin. These tumors also express synaptophysin, but don't express chromogranin. That's the catch. Because sometimes when you're dealing with an adrenal tumor this time, you want to differentiate between, is this an ACC, adrenocortical carcinoma, or is this a pheochromocytoma? Is this from the adrenal medulla? And synaptophysin is expressed in both cortex and medulla, but chromogranin will only be expressed in pheochromocytoma. So this difference, like, because we always expect synapto and chromo to go together, it doesn't always happen, They're cathepsin A negative, SMA negative, right? Negative for HNB45, markers that we use in AML, and they are usually vimentin positive. There's one caveat with oncocytic ACC. It tends to show a lower expression of SF1 than conventional ACC, right? So be aware of that. Maybe add some extra markers like inhibin A, melon A, add them to the mix to be sure that you're, you're differentiated. And now one last thing that I want to show you. One last thing that I want to mention is, you notice cytokeratins are negative in these tumors. So you might get fooled, cytokeratin negative, PAX8 negative, you're thinking AML, right? Epithelioid AML. Adrenal cortical carcinomas are negative for keratins, for most keratins. Sometimes they may show patchy staining, or focal staining for CAM5.2 or pancytokeratin. But if you see diffuse and strong positivity for cytokeratins in a tumor that you think it's an adrenocortical carcinoma, think again. Think about a metastasis to the adrenal. It happens, just think about it. And the last thing that I want to say, because it took so much time because I talk a lot, is it's a soft clue. I mean, we're currently doing the study on oncocytic ACCs with rhabdoid morphology. So I had the pleasure of reviewing 50-something cases. And one thing that I've noticed, because this differential is always, is it adrenal cortical carcinoma or is it a renal tumor? So oncocytic renal primary, So this comes up every time. So the thing is, what I've noticed, maybe it doesn't apply, but just my impression, a soft clue, is this rhabdoid morphology that you can see in ACC. I'm not seeing it that often. I mean, of course, high-grade clear cell renal cell carcinoma can have rhabdoid cells, but in an oncocytoma, in a chromophobe, in an eosinophilic variant of chromophobe, I don't know, haven't seen it that often. Nuclei are mostly central, But in ACC, in oncocytic ACC, very often you see diffuse areas that have these nuclei that were like compressed to the side of the cell. Maybe this is not necessarily 100% convincing for rhabdoid morphology, but I'm hoping to convince you, this is an ACC, that this definitely looks rhabdoid. You have that eosinophilic cytoplasmic globular inclusion and the nuclei that are pushed to the side, they're vesicular with prominent nucleoli. And also, the cells are discohesive. They're in this pseudo-alveolar pattern, very typical of rhabdoids-looking tumors in other organ sites. And in case you're wondering, these tumors, there are a small case series on rhabdoid morphology in ACC. Some people propose it to be an additional pattern next to the conventional oncocytic, myxoid, sarcomatoid. Sorry. There are these case series that they've looked at them immunohistochemically. They show retained INI1. They don't stain with MyoD1, myogenin, or desmin. So maybe it's just a morphological feature and apparently and definitely a pitfall if you have a biopsy, let's say from a retroperitoneal mass that looks like this. Maybe you won't think of adrenal the first time you see it, but you should keep in mind that this rhabdoid morphology happens, and it happens more often in oncocytic tumors, oncocytic ACCs. So that was it from me. I talked a lot. I hope you've enjoyed the whole thing. Kudos to the people that stayed to the end, because I really did talk a lot. And I hope you remember that the thing that happened was that was the fun part, yeah, of the whole thing. And if you have questions, I'm here to answer.
It is really fantastic. Thank you so much, Verena.
It was a great review. Thank you. I appreciate it very much.
No worries. I'm glad you were here and listened to me talk that much. Okay.
Thank you so much.
No worries. I'm very glad that we made this. Maybe we're gonna make it a recurrent thing. If you wanna, look at slide, I have some. I'm very active on Twitter, like I said, and I have all of my cases in a mega index. So you can check it out. There are links either to Kiko posts or to Twitter posts with, tutorials and explanations and pictures and videos and stuff like that. So if you want, you can check that out as well as my YouTube channel. I'm gonna share everything on our group, and maybe we can make this a recurrent thing. Who knows? Maybe we'll have fun more often. Okay, I'm glad we were here. Yeah, I'm seeing people saying recurrent, please. Yes, I'm very happy you liked it. So we'll keep in touch, right? Okay. See you all. I hope you have a nice weekend. Bye-bye.